Okay, good, perfect. So today we're going to talk, as Liz said, about the ethics of neurocorrection. And of course, first we'll have to explain what we mean by that. But to begin anyway, we'll start by imagining a particular scenario. So imagine that you're the judge presiding over a trial of Richard Smith. And this is a 32-year-old man who's been convicted by a jury of violent assault and who also has a prior history of violent behaviour and convictions for violent behaviour. Imagine too that this trial is taking place in the year 2051, and there now exists a pill that can attenuate or reduce impulsive aggression by increasing the level of serotonin in the brain of the person who takes the pill. So first question is, what implications might the existence of this pill have for sentencing in cases like Smith's? Would it be permissible in any circumstances for the state to require that Smith take the pill as a mandatory part of his sentence, or take it as a condition of his parole, or as a term of his probation, or as how in exchange for some measure of imprisonment or some traditional punishment? If so, under what precise stipulations? And also, should Smith be at least offered this intervention? Let's say, not necessarily in exchange for parole or in exchange for parole, but should it be the case that Smith is given an option of taking this intervention? So these are questions that mark the beginning of our discussion on the ethics of neurocorrection. So what is neurocorrection? So I'm borrowing here a definition from Tom Douglas at the Uehiro Centre and David Burks, who now works elsewhere, who define neurocorrection as the practice of deploying neurointerventions. And by neurointerventions, we mean interventions that exert a direct physical, chemical, or biological effect on the brain under the provisions of criminal justice for the purpose of reducing offenders' recidivism risk, the reoffending risk, and or facilitating their rehabilitation more generally. So that's what I mean when I say neurocorrection. So the use of some intervention that exerts a direct effect on the brain with the hope that this will facilitate, and the expectation that this will facilitate rehabilitation. Okay, so it's probably best illustrated by offering some examples of what might be classed as a neurointervention or an instance of neurocorrection. I hope my slides are still moving. Good. Okay. So currently there are two types of neurocorrectives in use beyond the research phase in some jurisdictions. So one is the use of opioid-substitution therapy, and that's the use of drugs such as methadone to reduce drug cravings and drug-seeking behaviour in substance-abusing offenders. So this sometimes can be offered to offenders as part of an addiction program. But let's say, for example, in the United Kingdom, there is scope legally to have a drug rehabilitation requirement where substance abusing offenders are required to undergo opioid substitution therapy. So that's one type of neurointervention that's already in use. Another type of intervention that, of course, has sparked much debate and is quite controversial is the use of anti-libidinal intervention, which is the use of, again, drugs such as CPA or MPA, which reduce testosterone and hence the sexual drive of sexual offenders. An anti-libidinal intervention is used in many jurisdictions around the world. Sometimes it is offered without any conditions. But in some parts of the world, it's sometimes offered in exchange for parole or early release, or some statutes in some parts of the world are within the law. It's sometimes allowed to administer as a mandatory part of a sentence for repeat sexual offenders or some subsets of sexual offenders. But there's speculation that in the future we may have other neurointerventions at our disposal. Interventions to, let's say, reduce aggression, as we mentioned in the introduction, reduce impulsivity, or enhance empathy or moral reasoning. So there's some small-scale studies that suggest that selective serotonin reuptake inhibitors, these are drugs usually used to treat or manage depression or anxiety, may be capable of reducing impulsive aggression. And there's some evidence to suggest this is the case, a small number of studies in both clinical and correctional populations. There's also some studies that suggest that high-dose vitamin and mineral supplementation can reduce violent instances of violent behaviour in juvenile offending populations. And there's other more speculative research to suggest that brain stimulation techniques, so by these I mean things like transcranial magnetic stimulation or transcranial direct current stimulation, which is the use of either magnetic fields or electrical currents to modulate brain activity. There's some evidence to suggest that these, very speculative, that this might in the future be capable of reducing impulsivity, enhancing empathy, reducing aggression, or improving moral reasoning. And some of these stimulation techniques are non-invasive, so they involve the placement of surface magnets, etc. There's also obviously direct brain stimulation, which is more invasive and that involves the actual planting of electrodes into the brain, which obviously would be even more controversial. Okay, so I hope I've now explained what neurocorrections might involve. And as you can see, there's a wide range of pharmaceutical, nutritional, and stimulation techniques that might be used or harnessed by the institutions of criminal justice. So clearly, when we're talking about this sort of things, lots of ethical concerns are raised. So I was going to talk a little bit about some of the concerns that have been raised and some of the attempts that have been made to assuage them or to carve out a way in which there may be some scope to use neurointerventions in criminal justice if properly regulated. So I've grouped just myself the types of concerns into pragmatic objections and principled objections. So by pragmatic objections, I mean objections that arise because of things about the world or the way the world is, rather than in principle objections to using these things. So I'm going to talk about the pragmatic objections first. So whenever I talk about neurocorrection, first to people who have been unacquainted with this ethical debate, the first objections that people raise are usually of this kind. People are frequently worried about, given our past history of biomedical abuse, often involving offending populations, vulnerable populations like prisoners. Given this dark history that we have, it should give us reason to doubt the wisdom of deploying neurointerventions in the present day. So worries that because there have been abuses in the past that we shouldn't use such interventions now. And some scholars in the debate have voiced this concern, saying that we should assume that abuses will happen again, and this gives us reason to avoid using them. And some other people voice concerns about the non-ideal features of present-day criminal justice practice anyway. So you might point to the observation that there's a tendency to over-punish offenders in many societies, and the phenomenon of mass incarceration, and very many other things that aren't ideal about the way we treat offenders currently anyway. And some might say that regardless of the history, given the realities of criminal justice practice, we should not introduce such interventions in the real world. So, for example, one scholar, Jesper Rybert from Roskilde, he defends use of neurointervention against a host of principled objections, but then advances this pragmatic worry that even if there's no in principle objection to using neurointerventions, that we should not maybe use them in the real world, given the irrationality of criminal justice practice as things stand. Now, in response to this, there are a few points that could be made. So some might say that these sort of worries don't give us decisive reason to avoid using neurocorrection. And they may give us reasons to be cautious, but they may not count against all and every use of these sorts of neurointerventions. Some might point to how some use of neurointerventions might bring substantial benefits to those who receive them. For example, I point to how some substance abusing offenders who undergo opioid substitution therapy find it helps them very much. Some might also say that some sexual offenders who are very troubled by their unwanted sexual urges might also benefit and be willing to undergo anti-libidinal intervention. So some might say that while these pragmatic worries give us reason to be cautious, there might also be countervailing reasons why we might think that there's still merit to be had even for the offender themselves in offering. Some might also say that in some circumstances, in extreme circumstances where someone poses a severe threat, there are also other societal reasons that need to be weighed against these worries, these pragmatic worries. So there's discussions going on about these worries and whether it provides a decisive objection against using these or not, or whether they could be permissibly used with proper regulation. Most of the debate, however, in philosophical and legal circles focuses on whether there's principled objections to using these interventions or not. So I'm going to focus on three sort of general principled objections and some of the responses and some of the attempts some scholars make to assuage some of these worries or to discount these as in principle objections across the board. So in the early, when the debate first started, in recent times, many concerns were voiced about whether consent to neurocorrection is possible in the correctional context. So these scholars were assuming that if we were to use neurointerventions, that they should be subject to the same regulations as we would when we're using biomedical interventions in clinical contexts. So there should be a requirement for valid consent. And one worry is that even if we don't mandate these interventions, if we offer them, let's say in exchange for parole, or we give some more lenient sentence if someone undergoes these things, whether actually it's possible to obtain valid consent. So I'll move on to discuss that in a moment. So that's one worry. Another concern then is, or another question, is whether non-consensual neurocorrection might ever be permissible. So whether it would ever be permissible to administer neurointerventions in the absence of offenders' valid consent, or in cases where we are uncertain as to whether it is consent can be obtained. And then a final area of concern is whether, if we were to use neurocorrection in criminal justice, either in place of some traditional punishment or alongside some traditional punishment, whether these interventions might actually undermine the goals of punishment, for example, if they were quite beneficial. So these are different areas of concern. So I'm going to say just a little bit about each of them, and hopefully we'll discuss when we go to the question time at the end. So first, the question about the impossibility of consent. So here we're starting from the assumption that for it to be permissible to administer these interventions, there has to be valid consent to them. And by valid consent, I mean morally transformative consent, consent that creates a permission for this intervention to happen. And some early contributors to the debate doubted that there could be consent to neurocorrection if it was offered when people are, let's say, in pre-offer situation is in prison, or the alternative is imprisonment. Some argued that offering your intervention as an alternative to, let's say, continued imprisonment is inherently coercive and undermines the voluntariness of the choice to undergo it, because the background liberty loss means that an offender couldn't choose freely and voluntarily. However, some people have said that this view of coercion and consent underminingness is over-inclusive, because if we think that when someone is offered an option in a position of restricted liberty, or where the alternative is unpleasant or undesirable, if we think that, then it creates unintuitive implications. So we might, that it would imply that if we have a competent terminally ill patient offered a risky yet life-saving medical procedure, potentially life-saving medical procedure, that because of the negative or the restricted liberty involved in the choice, because the alternative is so bad, and because the other options aren't available, that the person isn't capable of consenting to, let's say, undergo this procedure, which is counterintuitive. We would think that the person could validly consent. So then there's been a lot of debate about what is actually required for an offer to be coercive. And some argue that there's no such thing as coercive offers. For something to be coercive, and hence, consent undermining, it needs to involve a threat. And some have argued that if, as per the dominant view, punishment and imprisonment is justified, assuming that we're not over punishing or doing something excessive, and if the offender's rights are not being infringed in their pre-offer position, then there is no threat being made when the alternative to acceptance is continued imprisonment. The argument is that in this case, if the person chooses not to accept, they are just continuing what they would have been subject to anyway, so there is no threat involved. So that is one response to this sort of thing. Of course, then there's the worry that something cannot be truly voluntary if you're choosing between two different evils. So it could be the case that maybe it's not inherently coercive, but in real world situations, when we tend to have, particularly in some countries, very, very harsh prison conditions, then it may be seen that there's no real option, or that there's very much pressure to accept when the alternative is so bad, continued imprisonment. However, on the other hand, you could say that if we had what might be described as more minimal incarceration, which some might say exists in some jurisdictions, let's say in Norway, it might be seen as we don't have a situation of choosing between two evils. It might also be the case that if some of these interventions were actually very beneficial, that someone may actually want them, even if there was no conditions attached to them. Someone might actually want them even if their pre-offer position of imprisonment was unpleasant, and be willing to choose it anyway, even if it wasn't the case that there was this offer in exchange for early release. So it may be that whether or not consent can be obtained is a highly contingent matter. We may have no straightforward answer, or it may not count as an objection to neurointerventions across the board. But it'd be interesting to see what people think in the discussion. So some people then have gone on to examine the question of whether non-consensual neurocorrection might ever be permissible. So here we mean the situation where either neurocorrection is mandated, where it's offered as a condition, let's say, of parole or early release, and we doubt the validity of the consent that happens there. And some scholars, some authors have argued, no, it's not permissible for various reasons. And they say that there is a requirement for valid consent because in the absence of obtaining consent, we reduce and or disrespect offenders' autonomy, and autonomy understood roughly as their control over their own lives. Others argue that if we administer neurocorrection non-consensually, or in cases where consent is doubtful, we infringe offenders' moral rights to bodily and mental integrity. That if we administer things without consent, we infringe rights that are recognized morally and also that are protected in law. At least in human rights law, bodily and mental integrity is protected. Others have argued that maybe, in some circumstances, non-consensual neurocorrection might be permissible. So, for example, some have pointed to how, before I go on to this point, I want to mention that, so one objection is that in administering neurocorrection non-consensually, you reduce the recipient's autonomy, control over their own lives. But someone might point out that at least some neurointerventions enhance people's autonomy. So, for example, in the case of opioid-substitution therapy, if a person is addicted to a substance and they don't, and it's controlling what they do, their addiction is compelling them to do certain things, there is something impinging or reducing their autonomy in that case. And by helping alleviate that addiction, you may be restoring autonomy. Some might also say the same if it's the case that one has quite a lot of compulsive behaviour, say impulsive or compulsive sexual urges, or if someone is a very, very poor impulse control, they might be seen as somewhat a slave to their impulses. So it could be argued that sometimes neurointervention might restore a person's autonomy. Even aside from that, some have argued that potentially on some occasions, the importance of respecting persons' autonomy. So someone might say it's not a question of whether it reduces, but actually you're disrespecting someone's autonomous choice if you administer it non-consensually. And someone might argue that the importance of respecting persons' autonomous choices can be overridden on certain occasions, certain extreme circumstances. So I think Tom Douglas and Johnny Pugh from the Centre have pointed to how sometimes when there's severe threats to public safety or health, let's say in the case of pandemic control and things like that, that we do sometimes override people's autonomous choices. We have lockdowns, we have various things like that. And sometimes when there's severe health threats, we think that it's all things considered permissible, or some people think it's all things considered permissible. Another point might be that criminal offending might sometimes render a person morally liable to neurocorrection. So if we think that some forms of punishment are justified, or some responses to criminal offending are justified, that in committing crime, an offender renders themselves morally liable to, let's say, imprisonment or some other form of detention or some other form of sanction, why might it not be the case that in offending, some offenders render themselves liable to neurocorrection, morally liable to neurocorrection? So that's a question. Could it ever be that they also render themselves liable to that? And it may be that in some cases, neurocorrection is more humane than current sanctions that we accept that offenders might be morally liable to. Now, of course, you could return here and point to the differences between, let's say, neurocorrection and maybe other sanctions that are currently at play, and speak about, let's say, people's rights to bodily integrity and mental integrity. But again, it could be argued that the rights to bodily and mental integrity might sometimes be permissibly infringed. And for example, we might talk about how it might be permissible to mandate vaccination in routine child or healthcare worker vaccination programs, or possibly in pandemic control. And we might think that while the right to bodily integrity is quite a robust right, it may not necessarily, the level of intrusions on bodily integrity that some of these interventions might have, might not be any more intrusive or greater infringements on bodily integrity than some of these other things that sometimes we think are permissible. As regards mental integrity, whether persons have a moral right to not have their mental life interfered with, it might be the case that neurocorrections infringe impermissibly against that right, but it might also be that some things that we do anyway influence people's mental life, let's say like rational persuasion, or sometimes nudges or subliminal messaging that sometimes can influence people even without invading their bodily boundaries, that there still can be an invasion of mental integrity. And the problem, I suppose, the worry is that the moral right to mental integrity might be very over-inclusive if we're thinking maybe that some instances where people's mental life is altered without their explicitly kind of allowing it to be, that we don't think there's a problem with it. So to try and pinpoint what is the problem here, and it might be that some interventions might be permissible, all things considered, because the rights that they infringe may be no more robust than the rights to freedom of movement and association that are already sometimes infringed in ways we punish people anyway. So we might talk a bit more about that later, because obviously it's a big topic of debate. So I'm just going to move on swiftly, because I know I want to leave some time for questions at the end. So I just wanted to say a final class of objections that might be posed are worries about the compatibility of neurocorrection and punishment, or pursuing the goals of punishment. So someone might think that neurointerventions would be insufficiently retributive, so that they would be insufficiently harmful to allow offenders to get the treatment that they deserve, in proportion to the gravity of their offence. So someone might think, and this hasn't been voiced by any scholars of retributivism, but a worry might be, particularly if these interventions were very beneficial, that if they were offered to offenders in exchange for early release or as an alternative imprisonment, then there might be, particularly in the public sphere, concerns that offenders weren't getting what they deserve. Another worry might be that such interventions, again, if they actually were beneficial, might be insufficiently deterring. That if there was a prospect of receiving this instead of a long prison sentence, that it would be insufficiently able to deter future offenders from committing crime. And again, this concern hasn't necessarily been voiced by scholars, possibly because some interventions, let's say anti-libido intervention, have a lot of side effects. So we assume that maybe they wouldn't have this problem. But if these interventions actually had fewer side effects, this might be a worry. And another worry is whether these interventions might be insufficiently communicative. So one professed goal of criminal punishment is to communicate to those who have offended the disapproval of society and the censure. And again, if these interventions actually were quite beneficial, it might be seen as it wasn't communicating how harsh or how severe the offence was. Also, someone might say that in order to communicate to an offender the gravity of their offence and the censure, you would need to actually rationally engage them. And these interventions, in acting directly on the brain and in bypassing rationality, do not rationally engage offenders. And someone could point out that many of our traditional punishments, such as imprisonment, don't rationally engage offenders either. And it's often accompanied, if it is to rationally engage offenders and to properly communicate, it would maybe need to be accompanied by rational dialogue, which could be the case for neurointervention too. And someone might actually think that maybe neurointervention might sometimes enable the goal of communication. For example, if it enhanced offenders' empathy or moral reasoning. Okay, so I just want to say one last thing. So all this debate is centered on whether or not it's permissible and questions about consent, and whether there's some pragmatic objections to introducing them. So one thing that I worked on during my recent PhD was the question of whether offenders have a right to be offered rehabilitation, so at least offered. And I argued, I used the term neurorehabilitation to talk about neurocorrection as the subset of neurocorrection that is geared towards rehabilitation and not also trying to achieve, let's say, punishment. And I said, I was arguing that the arguments that have been advanced, the moral arguments that have been advanced in the past and by others in support of a moral right to rehabilitation more generally, imply a moral right to be offered neurorehabilitation in certain circumstances. So when neurorehabilitation or neurocorrection can be expected to be part of the most effective package for facilitating rehabilitation, and when it can be carried out safely and at reasonable cost. So I was arguing that the reasons we might have for justifying a right to rehabilitation more generally imply a right to neurorehabilitation in certain instances. So the three reasons that have sometimes been advanced is that persons are entitled to rehabilitation as an antidote to the negative, the debilitating side effects of punishment. People have a right to rehabilitation in order to preserve the right to hope for renewed liberty or renewed reintegration into the community. People have a right to rehabilitation in order to redress systemic injustices that may have causally contributed to their offending. So if an offender has the root socioeconomic causes of crime, that if they haven't been addressed prior to the crime and they causally contributed to the crime, then offenders have a right to some sort of redressing of the systemic injustice, and one means of doing so might be to offer them rehabilitation. So these three reasons, I argued, in certain circumstances extend and imply a right to neurorehabilitation, to be offered neurorehabilitation. But I think I'll stop there